So why do you have to document and bill properly for ambulance? What is it about this that drives the train? A lot of field providers think, oh geez, I have to get the patient's insurance information. I have to get the patient's Medicare insurance. You know what? Medicare is not insurance. Neither is Medicaid. Medicare and Medicaid are part of the law. And Medicare is federal, and Medicaid is a combination of both federal and state. So there are federal laws that drive how Medicaid is handled, as well as each state can design a Medicaid program based on their budget and what meets their needs. President Johnston signed the Social Security Act 50 years ago. 50 years ago, ambulance coverage and how it was handled was created, and it has not changed in 50 years. The basic issue is, if it's medically necessary for the patient to be in an ambulance, then ambulance transport is covered. And the actual language from the Social Security Act is the ambulance benefit is defined as an ambulance service where the use of other methods of transport is contraindicated by the individual's condition, but only to the extent provided in the regulations. So it is about the patient needing to be in an ambulance, that is the best way to take care of the patient, not just because you were called, but it is the best way to take care of the patient. So when we look at documentation, there are a lot of things that have to do with documentation that have nothing to do with reimbursement. First and foremost, this is what records the encounter with the patient, and it allows us to communicate to other healthcare providers. This record will follow the patient through. In fact, I have seen where the ambulance record is used when a decision is made whether or not a patient should be admitted to the hospital. Sometimes the ER doesn't have its tests back in enough time, but what you found when you got to the scene of the patient in an emergency situation will help them to decide whether or not that patient should be admitted. So that is a very important record. It serves as a tool for quality improvement. We look at our patient care reports, we look at them and we see, hey, did we handle this patient properly? Is this someone who should have received a cardiac monitor? How was our response time? Did the crews do everything that they were supposed to do? These are all issues that are looked at with the patient care report. It meets regulatory compliance requirements, and it's used to upload information to counties and states. You've heard of NEMSIS. There are different ways that states gather information. Some states are a little bit more robust than others about doing it, but the information from our trips does get uploaded to the counties and the states. Documentation protects people in case of infection, exposure, or violence. Think of Boston EMS at the time of the bombing. Think about this word that nobody was discussing 3 years ago, and yet it became everyday vocabulary and part of the 6 o'clock news every night. Ebola. When Ebola became a big concern, services all over the country went to the drawing board and they said, could we handle this? What are our policies and procedures? We had to do a check on ourselves to see if we could handle something like that. What would we do with infectious diseases? What would we do if we were exposed to a biohazard? And so documentation helps us know what we've done in the past and how we're handling it now and going forward. It might prevent lawsuit or act as your best defense. Did you know that if there is ever an audit, they can go back 4 years? That's their routine go back on an audit situation. And most providers worry about risk from the perspective of what happens if I was in an accident? What happens if the patient was dropped? And those are risk concerns, but they are far less likely to happen than audit. You are more likely to have somebody knock on your door at home at dinner time. I'm serious. At dinner time, with little badges and sometimes guns on their hips, just to be emphatic. And they'll want to talk about if an organization was ever audited, that could happen. And so documentation becomes your best defense, but it serves more purposes than you ever realize. This was a case, and I talked about this one yesterday. I had a trip come to us because we do auditing and we help people clean up billing problems, and this was a trip that had not been paid. So it was brought to us to help the provider figure out how to get it paid, which we ultimately solved, but this was the story. There was a 911 call for a 2-year-old with a vaginal bleed. Doesn't that just give you the shivers already, because you know this isn't going to be a good story? Paramedic responded to the call. Now, daytime, he was a paid paramedic. This was in his regular fire company that he ran as a volunteer, so it was his volunteer shift. So he gets this call, he shows up, and he knows that something's more going on than meets the eye. The mother has the baby in, I guess, the living room of the house, and the baby is clinging to the mother, and her hair is damp, like little curls that are damp. He immediately takes the lay of the land, and he documents everything out the wazoo. Documents what he found in that room, documents the people, documents the situation. And what he says to the mother is, I have to wash my hands. She points to the kitchen. He says, no, it's protocol. I must use the bathroom. It wasn't stinking protocol. He wanted to be in that bathroom and see. He gets in the bathroom and he sees blood spatter in the tub. And he sees wet and bloody towels. The mother's boyfriend was molesting the baby and the mother was covering it up. His documentation became the foundation for the DA's case against that mother. And they hung him by his family. Nothing less than he deserved. Nothing less than he deserved. Nobody thinks their documentation is going to have that kind of an impact, but that's why we have to be as thorough as possible. I talked to you already about the research that's going to go on with ICD-10 as we gather more information, but documentation is already used now for research. We're just going to get a whole lot better at it and get more data and more analysis of what's happening. And then last but not least, it's necessary to get paid. Money is really the last thing, not the first thing about documentation. It's the last thing. So how do you document? Well, spelling counts. And abbreviations get very unique in our industry. We see thousands of trip reports a year that come through our office. My staff audits patient care reports and they audit billing to make sure they're compliant, or to help providers if they missed any revenue opportunity, or to make sure they're not getting underpaid or overpaid. So we see thousands of them, and the things that people write in very unique shorthand are amazing. If you have an electronic patient care reporting system, and many of you do, although some still use paper, paper is fine, but if you have an ePCR system, it will be fantastic because it'll have drop-down boxes and it'll have things that'll help you speed through the documentation process. And that's great, but you don't want to be so speedy that you trip over your own 2 feet. So verify, if it's already pre-populated with the patient's name and address, verify you have the right patient, and double check that you haven't performed the modern miracle of EMS, and that you do not have a patient whose glass eye is mid-range and reactive to light. Because as good as you are, even you can't perform that kind of magic. So be careful. Describe what you see, what you hear, sometimes in our business, what you smell, and document what other people say to you. I read many trip reports and this is what it says: chief complaint, none voiced. Sometimes your patient is incapable of voicing anything. So, chief complaint does not necessarily have to be what the patient told you. Document statements made by others. Nurse at the facility, bystanders at the scene of an accident, the wife whose husband is clutching his chest and turning blue and he's diaphoretic and he is denying anything's going on, and she's like, he has been like this for an hour and I have been trying to get him to call 911 and finally I had enough and I called you. There you go. Now you know how long this has been going on and what's been going on. So you want to paint the picture, and if you use software, use it. Have it help you. It'll help you fill in fields. Just don't be so quick that it comes back to haunt you. Now, I love these two fellows. We've worked together a long time, and what I'm about to show you is abbreviations that we have seen in our audit work. Every single one of these, some of them I've seen more than once, have appeared on trip reports. And we were talking about this at dinner last night. Somebody said, I know a few more abbreviations. If any of you know any good abbreviations that would fit, send them to me. Be happy to include them in our list, but every one of these have appeared on trip reports as to why patients needed to be in an ambulance. So remember I told you, in an audit situation, they can pull back trips that are about 4 years old. Imagine it's 4 years after the fact and you're sitting in front of a jury and you are explaining what you meant by your patient being FUBAR. Yeah. And that jury is from your town. So, my favorite one, my absolute favorite is this. The patient's in the ambulance because they're TMB. Too many birthdays. Or they're SAS or OBE. Okay, this is how we text, folks. This is how, and spell check will not correct all of these. This is how we text. This is not how we should document trip reports. Use accepted abbreviations to document trip reports. Things that everybody knows, CHF, O2, COPD, A&O time X4. All of those are common. Now, obviously, there's some very serious aspects of patient care documentation, and it really comes down to an essential flow of information. They overlap each other, though. Some of these issues come from the same place. So first is dispatch. Whether you are an emergency or a non-emergency provider, how were you sent and what were you sent for? And dispatch information has a particular impact on emergency providers and can make a huge difference on what you get paid. When it's appropriately documented in an ALS situation, if you were dispatched for an ALS condition and you arrive on scene and you assess the patient and the patient doesn't need ALS and you do no ALS interventions, that is an ALS-1 emergency call that you can get paid for at the ALS level. I'll talk more about that as we go along. So dispatch information is critical, but overlapping it is kind of your operational, your field information, the clinical aspect of what's going on. What do your field providers find when they arrive? What kind of treatments do they do? How do they transfer a patient? Is it a two-man sheet lift? How do they do that? What's going on? What happens in the field? Comes together with the last piece, information that we need for billing. We need to know medical necessity for ambulance. We need to know fractional mileage. We need signatures. So when all of this comes together, the flow of information leads us to our patient care report. And so it really is three components. What happens from dispatch, what happens in the field, and what happens for billing. So we need to know how the call was received and dispatched, the response level. If you were dispatched ALS for chest pain, you were dispatched level 1 for chest pain, you were dispatched Charlie level if you use the Clausen method of dispatch, which is Alpha, Bravo, Charlie, Delta, Echo. Some people use that in a dispatch system. Depending on how big your dispatch is, whether you share information with police and fire, sometimes you get nothing more than you're sent for a sick person or a man down. But even so, Those pieces should get documented. The unit numbers, the times, the point of pickup, and fractional mileage, all of those are operational in nature, but they are necessary to a complete patient care report, as well as the patient's condition on arrival and during treatment and transport phases. And very critical for what we're facing with ICD-10 is the where, the how, and the what. The mechanism of injury. Where did something happen? How did it happen? And what part of the body was impacted? And we will get into that a little further as we go along. And reimbursement is why ambulance is the only way a patient must be transported, and what is it about the patient's condition that needs an EMT. Now, depending on when you went to school or what you were taught, everybody's taught a different approach to documentation. And in fact, when you become an EMT or a paramedic, there is a tremendous focus on documentation. There's a lot of focus on patient care, which, thank you very much. I want you to know about patient care if you have to come to my side, or for my son, or my family member. But it really is a style issue that many of you were taught. Some of you were taught SOAP, some of you were taught chart. Doesn't matter, they're all good. What matters is that you capture the essential information. Now, your organization may say, we want you to document in the SOAP style. Great. Good, awesome. There's no perfect documentation method. Just document. That's the perfect piece. And here's something that came up yesterday, and I'll talk about this a little bit. Sometimes billing people focus a lot on the narrative, and they will push back to field providers and say, we need narratives, we need more in the narrative, we need more in the narrative. I am here to tell you that you do need a narrative. Of course you need a narrative, but you do not need to write the great American novel. When I teach billing people, what I teach them is look at the entire trip report, not just the narrative. This isn't about sentences, and I went to parochial school. We were taught to diagram sentences. Gives you an idea of how old I am. And when we did that, you had to know all the pieces, the adjectives, the adverbs, the nouns, the verbs, and so forth. That is not the issue in patient care reporting. The issue is get the essential elements. And sometimes the essential elements of patient care report is elsewhere than in the narrative. And particularly when you are looking at history of present incident, history of present illness, the HPI, sometimes that may not appear in the narrative, it may appear someplace else. So it is the whole trip report that counts. The narrative is important, but it is the whole document, not just this little piece of the document that counts. And you'll find that a lot of the electronic systems try to make the rest of it as easy for you as possible, so that the narrative, which is the one thing that you freestyle, is a little bit easier go. So narrative is important, should be there, explains things that you can't explain anyplace else, but it is the whole picture of a trip report that is essential.